This conference will now be recorded.
This is John Antonucci. This is AnCan's high-risk, recurrent, and metastatic prostate cancer discussion group for the 6th of October, 2025. We'll get underway in just a second, but I want to thank our sponsors, Bayer, J&J, Myriad Genetics, Telix, Blue Earth Diagnostics, Foundation Medicine, and Novartis for supporting AnCan's efforts to have these groups. We have a couple of new guys tonight, so I want to just give you a brief description of how we run things. This is a 2-hour group, and it mostly consists of people bringing up any questions that they have related to their high-risk prostate cancer. We have a lot of shared experience in the group. So likely if you bring up something, there's going to be a number of people here who can tell you how they dealt with that problem, how they made that decision, how they coped with that side effect, and we'll be able to benefit everybody. For you new guys, we start the group off by asking you a number of questions about your medical history so that we'll be able to not only get to know you, but also be better able to advise you about what you came here for. So my first new guy is Bob. Bob is from Virginia. Now, usually, Bob, I'd be asking you a bunch of questions, but since I already know some things about you, I'm going to just go ahead and pass on the information that we've got already, okay?
Sure.
And then you can just fill in anything that I'm missing. Bob is an 81-year-old man from Virginia who was diagnosed 10 years ago when his PSA rose. This resulted in a biopsy and a Gleason score of 3.4, 3 plus 4. And I assumed that there were no unusual features in that biopsy. Otherwise, it probably would have been mentioned, right? Just regular old standard prostatic adenocarcinoma.
That's correct.
Correct. Okay. So Bob was treated in 2016 with CyberKnife radiation to the prostate. That's early for CyberKnife being used for an entire prostate ablation, but it's much more common nowadays. In 2018, a metastasis in the sacrum, as I understand it, was discovered and treated with SBRT. Okay, so far, Bob?
Yep.
Okay. In 2019, Bob was started on ADT. Does this mean for those whole 4 years you were not on any hormone treatment?
That's correct.
Okay. And he also had a PET scan which showed that there were some lymph node and bone metastases. In 2020, presumably because he was now considered definitely metastatic, although that was discovered 2 years before, apalutamide was added to his leuprolide, and he reached a non-detectable PSA in 2020. Was that the first time you got down to non-detectable?
Excuse me. Yeah. Actually, I went from, I think, once the prostate was treated, I was like a year and a half, and then it came back again. And so They did 2 more scans, one at Stanford, one at Georgetown. They found something in the bone, though the Stanford one doesn't report that. And then there was a lot of debate among the doctors of whether there was anything in the lymph nodes or not.
Oh. Okay. but the bone met was, we're pretty sure about that.
According to Dr. John Collins, who radiated it, yes. And he
Okay,
said it
so
was on the, I'm sorry, he said it was in the Stanford scan as well, but Stanford didn't report it.
Didn't see it. Okay. So now it's 2020. We've reached a non-detectable PSA after recurrence, and testosterone level is 5. Although he's having some of the usual ADT side effects, it seems to be generally reasonably well tolerated. A 2024 DEXA bone scan showed him to have a minus 2.3 T-score, but you're not on any bone strengthening medicine, right? You're just on calcium and vitamin D?
Correct. I'm going to have a tooth pulled to start that bone medicine. And at this point,
Okay,
not
so
ready
you
to
are
do
going to
that.
start a bone strengthener after your dental work?
I'm not sure yet. I'm not sure on the tooth pull because I don't really have to have that tooth pulled, but it's decaying from the inside.
Okay, so that could be another one of our discussions. So now we're on doublet therapy. PSA still non-detectable. Getting osteoporotic. Considering the possibility of a bone medication. He had genetic testing with the Invitae panel 5 years ago, which didn't show any metastases of interest. He is a non-veteran, exercising actively. Have I missed anything of importance?
No, I don't think so. I try to, that exercising, I try to do about a 2-mile walk a day as well as some small weights. My side effects, frankly, I think I've been blessed. I have, obviously some hot flashes, but they're quite tolerable. And I don't really have any fatigue like some friends of mine do.
Okay. So, since you're not at the present time having a recurrence, what brought you to AnCan at this particular time?
I've been fortunate in that the medicines seem to be working, but they could stop anytime. And the timing is a little bad in that the PSMA test wasn't available for me, say, right before some of those, the last radiation. So I have a curiosity of, really what is the extent of my cancer and is there anything more that could be done at this point, even though I'm considered low volume.
Okay. Okay, very good. Commentary from anybody? We've got a lot of people that have been in that particular spot. We have a 3+4 biopsy, which is something that would generally get a person a fairly conservative treatment. And in fact, it was years before he got on ADT, but we also have a bone metastasis, which has gotten him SBRT apparently with good results and now in remission. What do you think, guys, about his questions?
I thought you said you had more bone metastasis found in either 2019 or 2020. Is that true? In a scan? You're muted, Bob.
Excuse me, thank you. No, they only found one in what the right sacral wing, I guess, and the rest were some flares in the lymph nodes, and that's where a lot of debate existed between the doctors at Georgetown as well as at Stanford as to whether they were prostate cancer or something else. And the radiation doctor I went to at Georgetown did not want to radiate those areas because they were close to some vital organs.
Who's your current radiation oncologist?
Actually, I'm not using a radiation oncologist right now. I just have Dr. Nancy Dawson at Georgetown as the medical oncologist.
How do you spell her last name?
Dawson.
Okay. Anybody know her?
Retired colonel out of the Army, I believe.
Ah.
Correct.
Is she a GU med onc? Does either of you know?
Yes.
Okay. Now, one question that gets raised, we've already briefly addressed the bone question. Your bones are thinning as a result of a number of years being on ADT. And since you're getting down into the osteoporosis range, and since you did have a bone metastasis, this is why I was asking on being on some type of a bone strengthening medication. So you didn't really ask to discuss that point, but you're underway in the process of deciding whether you have to have the dental extraction. It sounds like you're favoring going on a bone strengthener. Would anybody argue that he should or should not be on a bone strengthener at this point?
The bone doctor on a recent prostate cancer conference said specifically that everybody on ATT should be on a bone strengthener. I was on Fosamax for 6 years. It's pretty easy. I even had a tooth implant done while I was on it. I've been on Zometa since then, but it's kept my bones strong, and because I found out from falling that I'm not breaking anything. That's
Is that how you figure out whether your bones are fragile or not?
Well, you get a DEXA scan, but it's that was the first key. But you really, the doctor was just really emphatic about the fact that he's a bone specialist, that everybody on ADT should be on it. So
Jeff, I've never heard that. I've never heard that before. Has that been corroborated by any other experts or physicians that everybody on ADT should be on a bone strengthener?
I think it is a little bit of a fringe opinion. Generally speaking, we're looking for either bone metastases or a poor score on a DEXA scan before bone strengtheners are considered, right, Jeff?
Well, yeah, osteopenia should, if you get that, then it's definitely time to do it. But my GU oncologist got me on it right as soon as I got on ADT, and I know I've heard from other people that that their doctors have told them the same thing. But this bone specialist in this conference was really emphatic about it, and about the fact that people don't get on it, their bones definitely deteriorate.
What is a bone specialist? What does that mean?
He was, that's what he said. He was a bone doctor. I actually probably have the video, have the slides from that, and I could look it up.
Okay.
I just remembered exactly what he talked for about 45 minutes, and he was real specific about it. And he's specializes in prostate cancer bone issues.
And
John,
Larry, go ahead.
John, I've looked at the possibility of bone strengtheners. I'm sort of just in the osteopenia level. I've got a bone scan coming up in the spring, and we'll see what that shows. But the side effects, particularly jaw necrosis and some of the other, actually, I've seen a bunch of things that talk about bone strengtheners actually promoting fractures because of the way they induce bone to grow. And I'm wondering if anybody here is on bone strengtheners, has had that sort of, have had any bad effects, any reactions.
Yeah, the
I'm
bone, when you are on some of these drugs, they interfere with the reabsorption of bone, the natural reabsorption of bone, so that the bone cells that are building bone can be relatively unopposed. However, just as you point out, for some reason, the bone that's built up has a bit of fragility to it. Now, in general, you're still likely to have less fractures, but you're right. The bone is not the same exactly as normal bone. Now, I think Larry's got some interesting comments about this whole issue that might surprise some of us. Go ahead, Larry.
Thank you very much. I hope you've all seen what I put in the chat. I've been using estradiol to suppress my prostate cancer for over a year. When I started ADT, I took a bone scan and I was a little osteopenic. 11 months later, my bone density is improved. And it's pretty well known that postmenopausal women get their osteoporosis because they don't have enough estradiol. Men have between 15 and 50 nanograms per deciliter of estradiol in their system that is manufactured from their testosterone. If you suppress the testosterone, that estradiol goes down, and so men get the same osteoporosis that postmenopausal women do. So a low-level supplement of estradiol can protect your bone in a more natural way than biphosphonates and stuff like that can do.
So did you get that, Bob? There is a hormone that can be added in low doses that might help reverse this process, or at least, if not reverse it, at least slow it down, in addition to the possibility. Now, who would actually do the prescribing for your bones? Usually something like Larry is talking about would come from a medical oncologist, but bone medications sometimes come from an endocrinologist. Who have you got working for you in this regard?
They could not find an oncologist to prescribe the estradiol, so I'm with the VA for my health care. My Alaska VA said they would dispense estradiol if I got an oncologist to prescribe it, a VA-approved oncologist. I couldn't get that, so I went to a gender care specialist, convinced her that I was serious and sincere, and so I got the high-dose estradiol, which also works. And my PSA has been below measurable levels for over a year. 0.014 is the bottom level that the VA lab can tell me. The side effects I had on Orgovix are mostly gone. Hot flashes, mood disorder, depression, anxiety, irritability, and cognitive decline. So I'm doing better on high-dose estradiol. And I'll give you a website, estradiolinitiative.org. No spaces, no punctuation. If you want to learn more, or send me a private message, I can share my research.
So, Bob, I got a couple of people with comments coming in, but let me just summarize what Larry said. The traditional bone strengthening medications are in a couple of different categories. They're bisphosphonates and monoclonal antibodies. Larry is talking about either adding estradiol in low doses to help stop this process, or even raising the dose of estradiol, and in which case he would be ditching your apalutamide. Right, Larry? He wouldn't need apalutamide anymore if he was on high-dose estradiol, right?
I believe apalutamide may be able to help. It's an ARPI, not a testosterone suppressor. It interrupts the testosterone joining the androgen receptors.
So
But
he'd stay on his apalutamide while ditching the leuprolide,
I never took leuprolide. I took Orgovix,
but you took
and
Orgovix, yeah.
I've never had apalutamide. It
Okay,
could
so
it
these are
could help
these are
with it.
strategies for you to consider, Bob. I'm going to just move on and catch some of these comments so I have time to go on to our next new guy. Dan?
Yeah, thanks, Bob. I was diagnosed after the radiation therapy with osteoporosis and penia earlier this year, 9 months ago. So they put me on reclassed, and I've been taking vitamin. In addition to that, been taking vitamin K and calcium, along with hydro, hydrolonic acid, at least
Hyaluronic acid, yeah.
hyaluronic acid twice or three times a day. It's really helped to improve my situation. But we discussed this same situation about a month ago with Larry. And so I brought it up with my PCP and my um, oncologist, and they refused to even consider putting me on estradiol. So I think it's going to be subjective to who you're dealing with, the
Hmm.
medical doctors.
I wonder what Nancy Dawson would think about the. Does anybody here have Nancy Dawson for their medical oncologist? No. Okay. Thank you, Dan. How about Tom Matika? Thomas Matika, you have your hand up.
Yeah, I've got a question. Can you hear me? Yeah, you can. Okay, I've got
Yep.
a question, Larry. Larry, what sort of monitoring did you have done when you took the estrogen? I think I think it was a topical application, wasn't it? And what were you looking at in terms of blood work, clotting, and things like that?
Taking estradiol or any estrogen orally has clotting problems, but if you take it through the skin and bypass the digestive system, you don't have that problem. You can take it through patches or a dermal gel. Um, Injections are working better for me. If you go to the estradiolinitiative.org, you can find out more information about a group of guys who are trying to get it FDA approved and adopted as standard of care. Um, I'm running pretty darn high estradiol levels, but when I first started, it dropped my PSA and testosterone pretty fast. I ran out of supplies, and the drop slowed down. I started Orgovix, and the drop continued at the original estradiol rate. But then I had some side effects, and I finally got the prescription. So I quit the Orgovix and used the high dose estradiol. I was wearing like 6 patches at a time. Most guys run 3 or 4, but that managed to suppress my testosterone and PSA well enough. But it was inconvenient, so I switched to injections, and that has kept my PSA suppressed really well.
And
But I'm running.
in terms of Thomas's question about monitoring, Larry, did you have
I
to
was
have
at
clotting
I
tests or other blood tests to monitor you?
my first oncologist put the fear of God in me about organ effects to organ systems. So I had CMP and CBC tests. He ordered them weekly. I switched that to monthly because those are going to be slower responding. But I was having PSA and hormone testing every week. As it turns out, that might not have been a really good idea because that's equivalent to donating a pint of blood every 9 weeks. I wound up anemic. So we're cutting back the testing, but I extensive testing. So I got a whole bunch of data to chew on over the past couple of years.
Lee Balin, you have a question?
I have a question and a comment. Larry, have you had any side effects such as gynecomastia or other such things that come from high dose estradiol?
Yes, I have. I decided before I started, because I looked up the side effects of all the different ADTs, and I looked at these things and said, you know, these are uh, not attractive to me. And I found out about the estradiol, and I said, you know, I'll take having breasts over having osteoporosis in any day of the week. So I decided that I would not be bothered by that. And yes, I have A cups.
Let me explain to Bob that one of the potential side effects of that hormonal approach is enlargement of the breasts. Thank you for that question, Lee.
Yeah.
Al Latimer, you got a
Yes,
comment?
that is preventable if you take a shot of radiation to each breast bud. I chose to skip that.
Yes. Al Latimer?
Yes, I just had a comment that I've been on high dose estradiol for a long time, and it kept my PSA undetectable for more than 10 years. And like Lee, my bone density increased, and I haven't really had any other problems with it. Well, I did have gynecomastia. I ultimately had my breasts. I had a double mastectomy because it got to be ridiculous. But that was a long time ago now, and I'm glad I did it. And I'm still on the estradiol now as part of my treatment plan.
Thank you. Jack, you want to wrap up this discussion and then
Yeah,
I'll
wrap
go
it up
on to
only
the
by,
next guy?
yeah, I'll wrap it up only by saying that, Richard Wasserstug and Dr. Paul are heading up the initiative that's being discussed, the estradiol initiative. And I looked that up, and they're the main people involved in that. And they're our own AnCan
Mm-hmm.
colleagues.
Yeah, if you do end up deciding to look further into this, Bob, we have a couple of experts that we're connected with on the estradiol, uh, which you can tell is a little bit controversial and probably unfairly so. Bob, you also had some questions about the future. I'm going to ask you to bring it up at a future meeting if you decide to keep coming. We can tell you a little bit about what's likely to come in the future and also talk to you about uh, the possibility of de-intensification of your treatment. You've been at a non-detectable PSA for 5 years now. Your bones are starting to wear thin, and it might be even worth talking about when it might be time to go off the ADT for a break, even though you had one metastasis to a bone, which got radiated. So, well, please keep that in mind for a future discussion with your doctor or with us, okay?
Will do. Thank you very much.
Okay, welcome to the group. Solomon, let's get some history from you. By the way, everybody, all you new guys especially, keep a lookout in the chat. There's information flying by in that chat frequently. So Solomon, is that your first name or your last name?
First name.
Okay, and how old are you?
I'm 74
Where do you live?
in Southern California, Pasadena, California.
And would you like to give us your last name, or would you rather not?
Yeah, that's fine. I'll give you my last name, Tessema. Tessema.
Okay, thank you. We do keep some of this information in a database, and it's organized by last name, so that's why. When were you first diagnosed, Solomon?
I was first diagnosed. Actually, had an MRI in March, which shows some very concerning lesions, and a PET scan confirmed that in May, and then I had a biopsy end of May, and the biopsy confirmed cancer, 3+4, 1 out of 18 cores, and also did a genomic test, a GPS. GPS was over 47, which is very high risk cancer. So the biology of the cancer is very risky.
What was
High
the name
risk.
of that test, Solomon?
GPS.
GPS.
Yeah.
And what is it? What is it scoring? The risk of having a future metastasis or something like that?
Adverse pathology and future adverse pathology during biopsy, and also future metastasis. Yes.
Okay. And 47 is a high score for that
Yeah.
test?
Yeah. Anything above 40 is high.
Okay. So you're 3 plus 4, but nevertheless, your GPS score warrants that you might be in a high risk category. Did you have any?
Plus my PSA was 14.5, which is again relatively high.
14.5. Okay.
Yeah.
And tell me again what your PET scan showed. I didn't really get that.
PET scan basically confirmed the lesion, the concerning lesions that were identified by the MRI.
Where?
But it did not in the prostate.
Okay.
In the prostate only.
Okay.
The PET scan did not show any concerning cancer outside the prostate.
Okay. Okay. So that's quite reassuring. So have you had any treatment yet?
Yes, I had a prostate surgery.
Oh.
On September 2nd or 3rd, just a couple of months ago.
A radical prostatectomy or something
yes,
more? Okay.
Radical prostatectomy at Cake Medicine. So the result was, again, the Gleason 3+4 was confirmed. 4 was between 21 to 30%. However, there were some very concerning things, extra prostatic extension with the involvement of the bilateral seminal vesicles. That's number one concerning. The second one, lymphovascular and perineural invasion identified. In the pathological stage, it's PT3B NOMX, meaning distant metastasis cannot be assessed. The plan was to also do a bilateral lymph node dissection, but they were not able to do that because of the previous TURP surgery I had in 2021. Because of that, the surgery requires a lot of time, and they were not able to do. They just did only one lymph node, and that was negative. But they did only one lymph node. They did not do the number of lymph nodes they wanted to examine. So
I see. Okay. Well, it's unfortunate that you didn't get your lymph nodes taken. On the other hand, a PET scan at a time when your PSA was up there around 14 showed no lymph nodes, and so and no metastases anywhere else in the body. So you might actually not be an MX, but an M0. It's very possible. Okay, so go ahead.
Additional to really round up my high risk profile, my urologist ordered a decipher test to see recently, and I just got the score a few days ago, and it's 0.75. Again,
0.7. Okay.
Which confirms the biology of my cancer is very high risk. Another confirmation.
Yeah. Okay.
And I'll be meeting with them in November. We're going to do a PSA test, and I'm sure the discussion is going to be, given the very high risk, profile, nature of my cancer, given the fact that there is extra prostatic extension to seminal vesicles, lymphovascular and perineural invasion identified. Given that, he might recommend radiation treatment sooner than later. That's what I suspect, given the high decipher test. By the way, we have one of the participants has been very helpful in Mayo Clinic in guiding us. He's one of the members here.
Oh,
And I've learned a lot from him. I like to do a shout out to John Marche. Is it Marche?
Jeff Markey?
Yeah, Jeff Markey, yes. Jeff Markey has been amazing. Has been
Great.
educating a lot of people, so I need to give a shout out to him, okay?
Okay, thank you, Jeff. Now, so is your doctor at Mayo Clinic?
No, my doctor is at USC Keck Medicine. USC.
Yep. Okay, and who's your medical oncologist?
I don't have an oncologist yet because I've not been referred to. I've only worked with a surgeon so far. I did a consultation before that with an oncologist, and I ruled out that I was not, because of my enlarged prostate and urinary issues, I did not believe I was a good candidate for radiation.
Why not?
Because that will exacerbate the existing urinary issues. Basically, it will inflame the inflammation of the prostate will worsen my urinary conditions.
Oh, okay. But you still have urinary problems even though you don't have a prostate anymore?
Well, there is incontinence because I just had a surgery just a few weeks ago, so I have minor incontinence, which is getting better. But the urinary issues are also related to the bladder. I have an overactive bladder. That's still continuing, So that's something different. I've tried everything. The last 10 years, I had high BPH and high PSA for the last 10 years. I've been biopsied like 5 times before this last one.
Oh, jeez.
At UCLA, at Kaiser, and outside of Kaiser, and every time the test was negative, but I had a very high PSA, sometimes reaching 47. But most of the high PSA in my case was due to inflammation, to prostatitis, and not to cancer. But the last one, number 6, actually identified cancer after 10 years of biopsies and MRIs.
You happen to know how much your prostate weighed or how big it was?
Yeah, I think it was about 40. Actually, it was 2021. I had a TURP surgery because the enlarged prostate was causing more and more serious urinary issues. I had a TURP surgery to reduce the. So I believe it was around 40 cc, 45 cc after the TURP procedure.
Now, how many weeks now since your surgery? About 4 or something?
So it's about 8 weeks.
Oh, it's 8 weeks already? And you haven't had a PSA yet, right?
I'm sorry, is it 8 weeks? Let me see. I'm sorry, it's only about 4 weeks actually.
4 weeks.
I had my surgery on September 2nd, so
oh boy,
4 weeks.
Oh boy, they're working on getting estradiol to approved for men. So that means all this bullshit about the bones and osteoporosis, it'll go away. But, I'm sure the pharmaceutical companies will have something to say about that.
Well, Tom, he may
not. I
not.
understand it. Some people from our group are in there. They're working in that effort.
Thomas, he may not end up on ADT. Unfortunately, he's not going to be eligible for radiation, it sounds like. And if it weren't for some of these high-risk features, he probably would not even end up on hormone therapy at all. He'd probably have radiation. Let's say at 12 weeks, Solomon's PSA pops up to 0.2 or something like that. In other words, radical prostatectomy will have failed to cure his cancer. Then he might ordinarily be eligible for radiation, but they don't want to give him radiation because
excuse me. let me make a correction here.
Oh.
I was not a good candidate for radiation when I had my enlarged prostate. The problem was with the enlarged prostate, which had basically restricted the urethra and so on, and so the prostate will be inflamed, and then my urinary symptoms will be worsened. But now the prostate is gone. The prostate is gone, so those concerns are not there.
Right, right. But you said there's still some bladder problems.
Yeah, bladder, yeah. But the main issue there was actually the enlarged prostate that was starting to obstruct urinary flow.
Okay.
And that's the one. That was the main reason that after consulting with an oncologist and with the surgeon, actually the cake medicine oncologist confirmed that my urinary symptoms will be worsened because of the enlarged prostate. And then,
okay.
And the famous UCSF radiation oncologist, he also commented that people with enlarged prostate, like me, with previous TERP procedures, are not good candidates for radiation.
Okay. So you are kind of ready. You're kind of expecting that the prostatectomy has not cured you, and you're kind of expecting that when you get your PSA measured this fall, that it will not be zero.
No, that's not what I'm expecting. Based on the initial conversation with my urologist, and the fact that he ordered a decipher test to further stratify my risk profile, and given the fact that the decipher test is high risk, 0.75, I think when we meet in a few weeks, the discussion is going to be, should we wait for your PSA to rise, maybe in a year or two, or should we do treatment right now? And
Okay.
there have been studies that suggest for high-profile, high-risk patients like me, with a high decipher test and with some concerning risk profiles like extraprostatic extension, they suggest that there are experts that say that it's better to start treatment even within a year of the surgery, whether or not the PSA goes up.
Okay. Okay. So now I think we understand exactly what you're doing, and so you will have a major decision to talk over in November. Whether your PSA goes up or not, you're seriously going to be considering treatment. And given that you are not a great candidate for radiation treatment, which would be the usual first treatment, then you will be considering medications.
No, I'd like to make a clarification. I was not a good candidate for radiation when I had my prostate, my enlarged prostate.
Okay, so you might be a good candidate for radiation now.
Yes.
Okay.
Yes.
I mean, it would be the more usual treatment.
Yes. Yes.
Okay. What comments do we have from people? Jeff?
Yeah, Dr. Estafio came up with guidelines for when to have adjunct radiation, which is what he's talking about. And there were a number of different requirements that your PSA would be, hold on, I'll pull them up, that you have a PT3B or 4, Gleason score of 8 to 10, lymph node Mets, or decipher score of greater than 0.6. With greater than 2 of the following risk factors. So she wanted more than one. I thought he said PT3B. Did he say that?
Yes. Yeah.
Yes, but the Gleason score is not up there.
No, the decipher is high.
And the decipher score definitely is high.
Yes.
Oh, excuse me. greater than or equal to 2. So he has 2 of the adjunct radiation
Yes.
considerations that Dr. Stafford said that should be considered when doing adjunct radiation. So that's why he qualifies.
Jeff, even if the PSA is non-detectable, is that
No,
correct?
it was 2 or more of those issues, and he's got the PT3B plus the decipher. So that's what she specifically said during, and I've got the link to the whole article if you want me to post it.
Okay, very good. So Solomon is at least half expecting radiation therapy, regardless of what the PSA says.
Exactly.
Yep.
That's a consideration. Yes, that's something
Okay.
that we're gonna discuss. Yeah.
Would you like to hear from any of the guys that have been through radiation therapy?
Yes,
Guys?
I'm concerned about the side effects.
I think salvage radiation and adjunct radiation are essentially the same. I had salvage radiation about 12 years ago, and I had absolutely no side effects at all. Because it doesn't reduce, it's not prostate cancer radiation. It doesn't have most of the side effects of the serious side effects. Some people do get urinary tract problems. Some people have fatigue, but those are the most common things from salvage radiation, it seems. Maybe somebody else can say more. I just posted the link to that full article.
Okay, Steve.
Yes, I just recently or earlier this summer had 25 sessions of IMRT, followed by 5 sessions of SBRT. And I think I had a little bit of tiredness from it. No pain at all. I had one short episode of some bleeding in blood in my urine. Yeah, I thought it was very easy to go through.
Was this after a prostatectomy? Because that's what we're talking about.
No, I was diagnosed de novo, so I have not had a prostatectomy.
So the results are different with people who have had a prostatectomy, and that's what adjunct and salvage radiation are discussing, not initial radiation. It's not the same.
I had similar treatment as Steve, except for it was after a radical prostatectomy. My PSA rose immediately after my prostatectomy. I had what at the time was the traditional external beam radiation therapy, although nowadays Solomon may be talking about stereotactic radiation therapy, who knows. And I tolerated it well. During the latter part of the treatment, I had a lot of difficulty controlling my bowels, and that cleared up, and all was well until about 3 years later when I developed radiation cystitis, and now I have a grossly bloody urine frequently.
I also know people that had rectal bleeding, by the way.
Yes, you can also have, my brother had radiation proctitis with some pain and bleeding in the rectum. In his case, it was delayed about 2 years.
Okay.
Jim Aiken, I think you have your hand up. Let me just check here. Yeah, Jim Aiken. Are you there, Jim? He must have stepped away. Oh, there he is. Okay, Jim. Sure. Yeah, what do you got?
I originally had proton radiation at Loma Linda University Hospital, and we had a number of men in our class. I called it a class because there were about 40 of us at that time that had the surgery and were back for radiation, and they were doing proton radiation as opposed to photon, which is standard X-ray. So I would suggest that you consider proton. I had no side effects at all. 10 weeks I went through that program and there's literally no side effects from the radiation. Even though 10 years later, my bladder started bleeding, and then they credited that to the radiation. So I guess there was some side effect to that bit. So
Okay.
that's a comment.
Thank you, Jim.
What was bleeding? I'm sorry. What was bleeding?
My bladder. I had a
Oh.
bladder infection, but this was actually 12 years later.
Okay.
Where we really have to make sure that Solomon ends up with an excellent radiation oncologist this fall. So if anybody knows one in his immediate area, please say so. Don Rogers, you got your hand up? You got to unmute, Don. Could you unmute and then say that over again?
Yeah, hi. I had a radical prostatectomy in April of 22, and in July and August of 22, I underwent 34 sessions of external beam. I found it, and it's 3 years ago. I have not had any side effects directly related to the radiation, other than some issues with my bones. I've got a part of my femur which is necrotic because of the radiation, and in my sacrum there's a couple of breaks in my sacrum that they tell me is directly related to the radiation.
Was the radiation administered on the prostate bed or anywhere else?
The entire prostate bed, because I had positive margins, and I had a positive one positive lymph node and one positive seminal vesicle.
Okay.
They included the pelvic bed, right, Don?
Yes.
Pelvic bed and the prostatic fossa, both.
Yes.
Okay.
And Dr. Russell.
Yes, I had salvage radiation in 2008 after a recurrence. I had a radical prostatectomy in 2001, so it's been a long time. But the radiation produced pretty severe fibrosis in my bladder, so that my volume and capacity is probably less than 100 cc. So
Oh, that's small.
that's small. So anyway, nothing's for free, but I don't want to scare Solomon. But anyway, so it's another side effect of the radiation.
I'm going to have to move on now to the regular guys because I got about 10 or 11 and an hour left. But I want to make sure that if anybody knows a good radiation oncologist in his area, to please say so. You said Pasadena, right?
Yeah, Pasadena, City of Hope,
Yeah.
USC.
City of Hope must have a great one, right? This is where Rick really comes in handy. He knows all these people. So let me talk to Rick and then get back to you, Solomon, okay? Could you put your email in the chat box, Solomon, and I'll try to get back to you?
Sure. Also,
Okay.
I want to know if you know anyone at the Cake Medicine at USC as well.
Okay. Okay. Dan, you're first.
Oh, great. I've gotten through the last probably 8 to 9 months of side effects, and my PSA remains undetectable at 0.01. I wanted to take a holiday, but my oncologist is saying no, she wants me to take one more shot next week of Lupron, which would take me into January. The question I have is, should I start to consider being out of this group and into the low-risk group? That's the short and sweet question that I have.
Okay. Well, what are your major risk factors for aggressive cancer?
Well, my Gleason score was 4+4. The radiation therapy last year cut out everything, but as we discussed with the osteoporosis, osteopenia, they didn't really do the bone scans. So that's what I've been dealing with the last 9 months is the side effects of all that. And yet my PSA remains at 0.01. No Mets. It's just the side effects that I've been dealing with.
How about your genes?
All positive.
What do you mean?
No negatives. No negative genes.
Okay.
Or
No
mutations.
No mutations. Okay. Well, this group is for people, first of all, who are recurrent. You know, they've been brought into remission by treatment. A period of time has gone by and their cancer's come back, which you're not.
Right.
It's for people who are metastatic, which you're not. But it's also for people who have high risk. Now, what are your high risk features? You don't have any high risk genetic features. You do have a high risk Gleason score.
Right.
And do you have anything like Decipher scores or anything like that in your?
I never got that. I never took a Decipher test.
Okay. So it does seem. Here's the problem. I sit in on the intermediate and low risk group, and generally speaking, those guys are early in the course. They just had biopsies. They're trying to decide if they need treatment or not. Some of them are redirected into active surveillance groups. Occasionally, we'll get somebody in there that really belongs in high risk group because he's recurrent. But you're on meds now, right? For another 3 months, you said, or something like
Another
that.
4 months. I take a Lupron shot. I'm
And then,
off. I'm off Abby, and I'm off prednisone back in
yeah,
March. And the other part of that question is maybe I should, if I'm allowed to go on a holiday, just go to the low risk, and if anything starts to pick up again, come back to the high risk group. That's part of the question.
yeah, definitely. If you recur after a period of having a PSA of 0.01, going off medications, and then you recur, you're definitely in this group. Why don't you visit intermediate risk?
Sure.
How about that?
Yeah,
See what you think. It's going to be next Monday at 8 o'clock, same time, same station.
yeah, okay.
And Jim Marshall had his hand up.
Ah, well, I have the opinion is that what do you believe the chances that it will be back?
Like all of us, I cross my fingers, and
And
some of
hope.
us I pray.
I sort of look at this like every week as a training session. And what you want to do is to stop training for a year and sort of believe that everything is nice. And then you come back to us. And during that year, you miss maybe a lot of information. So even though you are in the state you are, you can just sit there and gloat, okay, at the rest of us.
No,
So
that's not
that,
the case.
so the,
You're
it
picking the wrong adjectives, Jim.
could be. I was being facetious there,
Well,
but
please, yeah,
either
thank you.
that or you can attend both of them.
Right. Exactly. I'm asking for advice, Jim.
Yeah,
Well,
we've got another guy like that, Jimmy. Jimmy is in a pretty long remission. He was a 4+5, I think, actually, but things have been so quiet for him. He feels funny in this group, and he was kind of wondering about where he belonged too.
And last Tuesday, he came on pretty strong. It was a different group in terms of all the activities, physical activities, the
Yeah, yeah, yeah,
weightlifting.
yeah, yeah. So, Jim, you think this is good training for the future coming with us?
Well, actually, I think it is
Yeah.
because every week it prepares you for what could happen, which you hope never happens. But if it does, you might be better prepared. So,
And
good choice.
there's something to be said about that. It's almost like lifting weights and doing your exercise. You just continue it along with if you're on medication or you're on any other kind of treatment. I fully agree, Jim. I'm asking for advice.
Any other opinions about that? I see there's some hands up. Let me just see who it is. John
You
G.
know, you know,
I just had a question. Do you have a GU medical oncologist lined
A
up just
regular,
in case?
a regu,
A
no, I have an on,
GU.
no, I have a regular oncologist who's pretty tight about things. Jim knows about her.
It's
Okay.
called
I'm just saying
Kaiser.
that.
It's
Yes.
called Kaiser doesn't have a GU medonc around here in the Washington area, but she is pretty good.
Right.
I have her too.
Boykin?
Yes, I was going to say I'm actually a moderator in the low intermediate, and so to me the concern would be um, a lot of the stuff that you've already experienced, the low intermediate guys haven't. So like when you start talking
Mm.
holidays and things like that, they're not going to be able to relate to that. So I think you can certainly monitor things, but as Dr. John said, we're dealing with folks in that group that are still kind of considering treatment options, or they're just post their initial and they're waiting for treatments or waiting for recurrence. So I think you have to kind of balance the personalities of the group. I think you should stay plugged in somewhere, and just by the nature of your questions, that may drive where you really need to fit in at.
This is kind of altogether leaning towards
Yeah.
staying with us. Boykin, do you think he should even visit the intermediate next week?
I think he can if it's. I mean, I'm going to be moderating it, so I think he can if he's just kind of interested. But it's not as obviously isn't as advanced. And I mean, I'm learning a lot just listening to this discussion here. So it's a
Hmm.
totally different discussion. So uh,
Mm-hmm.
I would say visit the low intermediate group um, at least once, just so you get a feel for what the group talks about, and then make your decision.
Thank you.
I think
I
it's like the
initially
different.
started out in the high risk group, and then I got moved down later on to the low intermediate, which is where I really am a better fit.
Thank you.
I will. I'll send you some information about Dan Boykin, and maybe he'll come and visit you next week, and maybe we'll see him again on Tuesday.
Okay, sounds great.
Jack, you trying to get a word in
Yeah,
edgewise
I
there?
just want to squeeze in. I'm just having a thought that it's like the difference between being in graduate school and an undergraduate school. You already graduated and you want to go back to being an undergraduate school, and you've been there. So I agree with everybody. You belong in graduate school.
All right, Mr. PhD.
Larry, what do you think?
You may count yourself as between groups.
Yes.
And I'm thinking, more information is better. You may
Right.
not be able to get information from the low intermediate group, but you may be able to share your
Right.
experiences and let guys know who are about to move up what to expect. And,
Yes.
yeah, I would stay in both groups, man.
Got it. Thank you.
Larry, as long as you have the floor, Larry, why don't you bring up what you wanted to bring up and about yourself?
I think I brought up most of that.
Oh, did you? Okay.
Yeah, 2 years ago I had prostatectomy. My PSA never went to zero. Started climbing at a doubling rate of 2 months, but 3 months at first. Then the slope got steeper. So I started, the Orgovex and the estradiol. I had cognitive decline, mood disorder, hot flashes on the Orgovex. Those all went away with the estradiol. My DEXA scans are improving with exercise, taking the vitamin D3 and K2, and the estradiol. The fly in the ointment is that my estradiol levels are approximately twice what premenopausal women get. So I'm talking to my pharmacist and my doctors about any way that can get that lower, but my testosterone levels are between 10 and 20 nanograms per deciliter. And if I let them go up to 30, my PSA starts to rise.
Oh.
So it's pretty aggressive.
So if you back off on estradiol, you're afraid that you'll make more testosterone and more PSA. Yep.
Yep. And both my parents lived into their 90s. That gives me about 15 more years. I want to make the best of them.
Yeah.
Do you ever monitor your luteinizing hormone and your FSH?
Yes, I was. Every week. As I said, is a bit much. They didn't change much, really. My sex hormone blinding globulin, though, went up. That keeps the free testosterone down.
I'm just curious what your pituitary is doing. What kind of work is your pituitary doing with the estradiol in contrast to if you were on ADT, where it would, shut off the FSH and the LH?
I don't know, but all my lab tests, except for hemoglobin and hematocrit and red blood cell counts, were fairly normal until I tested the iron levels, and they were low. So all my comprehensive blood count and the comprehensive metabolic panels, they were pretty much all straight across normal. I am diabetic, but that has improved over the past year.
Let me ask you one question. You're in Alaska and you're getting such cutting edge treatment advice. Did you get that outside of Alaska or within Alaska?
Internet. April of 2023, I got my diagnosis and I made a deep dive into research. I got a 100-page pamphlet from Prostate Cancer Foundation. I read it from cover to cover. Took it all weekend. And I have not stopped researching since. I pay attention to medical journals, not popular press. I've contacted Professor Wasserstug and Dr. Paul Schellheimer and Bob Watson in New Mexico, who are leading up the estradiol initiative group, and a few other guys that I've met through the internet who are using high-dose estradiol with good results. So, yeah, I'm vetting my sources very carefully and not getting carried away going down rabbit holes that are dead ends. Most of my research, though, is there's in vitro, there's animal studies, and then there's human trials. And I try to make sure that I'm paying attention to stuff that has a strong, level 1 experimental support, empirical report.
Very well done. Congratulations.
Thank you.
Thomas, if
you go into the medical journal articles, I've been advised to take a look not only at the article and what sources they use for their research, but also how many times that article has been cited by other researchers. That gives you an idea how good they are.
It's easy to get that information nowadays.
Yeah.
Thomas, you're the next guy on my list. What did you want to bring up tonight?
Okay, thank you. I'm a Gleason 9 with a Decipher score of 1, so I have very aggressive cancer. I'm coming up on the 2-year anniversary of being on hormone treatment. My current medical oncologist says I should get off after 2 years based on the Stampede trial. But with the aggressive cancer that I have, I'm looking to get another opinion on whether I should get off or continue on the hormone treatment. And I was wondering if anybody's had any experience. I'm thinking of going to see either Dr. Alicia Morgans at Dana-Farber or Dr. Andrew Armstrong at Duke University. I was wondering if anybody had any experience with these two medical oncologists and what their recommendation would be. Or if you could recommend something else.
Both of them very well-known, high-level people. Where do you live?
I live in Chicago, and I'm currently going
Chicago.
to Northwestern Medical down in
Yeah.
Chicago.
So you can't go wrong with Alicia Morgans or any of those. And there must be somebody in Chicago too. This is another time where we miss Rick.
What about Schmulowitz? That's the one Rick always mentions from Chicago. The one David's using.
Okay.
Yeah, that's a great idea. Usually, probably 2 years ago, your tumor board had a meeting and they decided on 2 years of hormone treatment. And you're basically, I assume you're in remission now. Your PSA is non-detectable.
Yeah, it's undetectable right now, yes.
Yeah. So you are entitled to a treatment break, but you have 2 things that say that you are likely to recur, Gleason 9 and a decipher of 1.
Right.
So the question is, will that recurrence, will it be faster and more aggressive if you're on a treatment holiday? And I don't know. I sort of feel I'm going to try to channel Len here a little bit. I'm going to make believe that Len is here. I think he might suggest that if your ADT is causing you quality of life impairments, then you might have a year of a better quality of life by going off the drugs. And when you do recur, which is predicted by these 2 risk factors, then you will immediately jump back on hormone therapy as soon as it reaches some predetermined level, like 0.2 PSA, maybe something like that.
Mm-hmm.
And you will have gained some time off ADT, having a better life.
I am able to tolerate the ADT. I mean, I have hot flashes and some fatigue, but it's not, life altering.
Yeah. What do some of the others of you guys think about this?
What feels comfortable for you, Thomas? What do you intuitively? What do you feel is right for you?
I'd prefer to stay on the hormone treatment.
I sense that. I sense that about you. I just went through that myself. I was on it for 2 years. I'm off of it for 6 months, and intuitively I felt I've got to get off of it. And I felt, and I said, let's do it. Let's go off of it. I'll take my chances. I needed quality of life. I'm also 86 years old, so I just wanted to, really feel some semblance of, whatever vitality I wasn't feeling. So I made a choice. And it's a gamble, but maybe yours may be more of a gamble because you have different, Gleason score than I had, and I'm 22 years out.
Mm-hmm.
There's also, there's Dr. Schmulowitz. Jeff posted it for you. There's also the effect on your bones and the effect on your heart to be thought of. Maybe they would recover a little bit. Yeah. Gary Peters, you got your hand up?
Mm-hmm.
Sorry, I just had to unmute.
Okay, dear.
Thomas, I saw Dr. Morgan's sometime in early 24, and went up to Boston to see her. But once I was talking with her in her office, she told me that their staff was no longer allowed to keep out of state patients. So she could not be doing telehealth with me.
Mhm.
And I thought, well, I wish I would have known this before I flew to Boston. But that's the story with her, unless they've changed the practice, which between then and now, I doubt they've changed.
Was she helpful? Was she helpful?
She confirmed some of the things I was wondering about. I mean, she was certainly helpful in that I got an opinion I valued from her.
Mhm.
I was looking to have an ongoing communication with her, through telehealth or through emails, and that was not in the cards.
Okay. I'm not looking to switch to her. I just want to get a second opinion on whether I should continue on hormone treatment. And I'm hoping that if I go to see her, that I'll get some very good information, and just wanted to know if anybody had any experience with her.
And she'll certainly give you her best analysis on a one-shot appointment, but I just didn't want you to think you were going to be able to establish an ongoing relationship.
I understand. Thank you.
Good point. Thank you. Thank you, Gary. Jeff, you got your hand up?
Well, Smolowitz at University of Chicago is really highly regarded.
Okay.
A bunch of people here have used them. Vanderweel at Northwestern, another one, has been very. I'm not sure they would probably be as good as going to Morgan's for you, and they are right there in Chicago. But have you been undetectable for more than 9 months?
Since November, so November of 24. So yes.
Yeah, I know that other doctors have said that as long as you've been at that point, we've had some people come in here that after 30 years with a Gleason 9, they had their PSA start rising. Another person with a Gleason 9 after 20 years. So stopping ADT and getting monthly PSA tests would give you an option to go right back on if your PSA starts rising. Or maybe you'll be lucky and your cancer has gone dormant, as it does for some people, and you will have, even though you're a 1, you might have a chance of no remissions. You should go to. I mean, those 2 doctors in Chicago would be a great idea for second.
Well, Dr. Vanderweel is my oncologist.
Oh, well, then go to Smolowitz in University of Chicago.
Yeah.
He is really, Rick loves him, and there's been a bunch of people here that have used him, and he's been really, really great to work with from what they've said.
Okay, thank you for the information.
Jim Marshall.
Let's see, a question for you, Tom. You say you're on ADT, but are you on ADT plus a second drug?
Yeah, I'm on Orcovix and abiraterone.
Okay, I was on those for 5 years, okay, and I took a holiday, and my holiday is now into 3 years and 2 months
Great.
so far, although it's just starting to rise up. Now, the bad part, maybe good part, is that staying on it for that long, my testicles have then given up the ghost. They are no longer, they just crapped out on me, which in a way is a blessing because it's a sort of artificial ADT.
Right.
Yeah.
Jim, have you concluded that because of your level of testosterone, or have you tested your pituitary function?
I have, because of the level of the testosterone is so low.
How high has it gone?
One time it got up to 49, but generally it's in the 30s.
And you're fortunately not sure, and your PSA is 0 still.
Well, no, it's up to 0.09, but it jumped to 0.13, but I just found out that I was experiencing a UTI for probably the last month, and I didn't, or two, and that could have caused that jump. So I will find out Friday
You still
because
have a
I'm on the
prostate.
meds and everything else, and so it is hopefully gone.
You still have a prostate, Jim?
Yes, I do.
Okay.
Larry. Gotta unmute, Larry.
Larry or Larry?
Okay, thank you. Yeah, if you do feel
Larry.
adventuresome and want to leave your current protocol, check out the idea of using bipolar ADT or finding a clinical trial that looks like it might be beneficial to you.
Okay. All right. Well, thank you. Thank you very much.
Okay, great question. Great question. Brian, are you still here? You're next on my list, but I don't see you anywhere. Brian's gone? Okay. Eric James. Are you still here, Eric James?
Yeah, can you hear me?
Yeah,
Hello? Can you hear me?
I can hear you, Eric. Hello? Seems like we can hear Eric, but he can't hear us.
Yeah, I didn't think you could hear me. My question is,
Okay.
I wondered if anyone had any experience going to see a medical oncologist out of state and what it's like trying to do that long distance.
Oh, I think there's a lot of such experience in this room, isn't there? Who's seeing an MO out of state? And how big of a problem is it? Joel? Gotta unmute, Joel.
Thank you. I see Dr. Estacio, who's in Texas, and I'm from Reston, Virginia. And it is a hassle, but I've been pleased with her care, so I don't mind. But yes, it costs money for travel and motels and so on, even though I can put you onto some free stuff if you need to travel, depending on what city you're going to. The main problem I have with Dr. Estacio is her staff. All the correspondence I get is for residents of Houston type correspondence. And they expect me to show up for an x-ray or whatever, a scan the next day, or where it's not possible. So I have to constantly remind them that I'm out of state. But that's usually the biggest issue, that I'm out of state and not a resident of Houston.
Okay, thanks.
We really very highly value having the very best of GU medical oncologists in general. So if you don't have one in your immediate area, then we think it's worth quite a lot of hassle to find a really good one. Fortunately, COVID advanced the practice of video visits quite a bit. I had heard that Medicare was going to stop paying for video visits as of October 1st. But now that the time has come, there's no announcements have come out, so I think we're still good, at least for that. Jim?
Joel, question for you. Do you still have a doctor around here within the Virginia area, or are you exclusively using her?
No, as a backup, I have Dr. Josh Allen of the Shar Center at Fair Oaks Hospital. And he's very good, but he just doesn't have the experience that Statue has. He's only, I think, 7 years or so into his practice. And I know a lot of men in the area who use Josh Allen, and they're happy with him. So, and he practices very closely with John Hopkins doctors. He relies on anything very advanced. He relies on John Hopkins doctors and he refers men to John Hopkins often.
Okay, I thank you very much.
Okay, guys, I've got 4 more on my list and a few that I couldn't get in touch with at the beginning, so we're doing good. Al Latimer, you're next. Are you still here, Al? Going once, going twice, Al Latimer? Oh, I really kind of wanted to hear from him. He's been having an awful lot going on lately. How about you, RJ? You want to update us?
Sure. Yeah, just a bit of a refresher on mine. So I got diagnosed back in May with a Gleason 9 intraductal large cribriform, pretty big extracapular extension. And then I got a PSMA PET scan that showed 8 different spots on it. I would say only one of those showed up on the CT as a bone lesion, but 8 different spots. So the doctors I've been working with have generally said, yeah, this is a low volume. And so then starting in July, I went to see a medical oncologist at Fred Hutch, and they put me on the Lupron plus abiraterone. And so I've been on that since. And then at the beginning of August, I started radiation. So I had 25 sessions of EBRT, and I survived that. I had some urinary issues that then my radiation oncologist prescribed Flomax, and that was like a wonder drug because I mean my symptoms were getting worse with the radiation, but I didn't realize how bad it was just trying to urinate, and so that made things actually much better than before the radiation. So and no real issues with that since. And then right at the very end, like at session 25, I started a little bit of radiation proctitis, and so that lasted for about 2 weeks, and it just let me know, I would say, how bad things can get. So also I know what to look for in the future. Like I know what proctitis is like. And then I will say, like the doctor put me on a suppository for that, and that helped a ton as well. So the side effects were essentially alleviated with some additional medication. And so then also I've gotten, since then I started beginning of let's see, it's September 23rd. I went in and I saw the medical oncologist, and so my PSA now is undetectable. So that's good news. And so it took a couple months to, July, August, into September. So between 2 and 3 months. And it was right around 12 down to less than 0.03. So they can't detect less than 0.03. So So that was good news. And then I started the SBRT. I got 5 sessions of that to the prostate bed. So that also covered 4 of those spots. So left iliac wing of the pelvis, right iliac wing, sacrum, and pubic bone. And then let's see, this week I have off, as far as I know. I have my follow up from my EBRT, but that's just going to see the doc on that. Next week, I have 3 more SBRT. Those are for lymph nodes, so external iliac lymph nodes that they couldn't get in the first set of SBRT. They're doing 3 more. And then after that, so that's the other two spots. So I have 2 of those lymph nodes on the left side that on the CT scan were not abnormally sized, but they showed on the PSMA with some spots. And then I'm going to get another session of SBRT, 5 days for my ribs. So 7th rib, left side, and then the right side is where the lesion that showed up on the CT scan was. So they're going to do 3 days on each. They can only do 5 days, so I have 1 long day. So that's what I have planned. And then I talked to the medical oncologist and I said, hey, like I'm gonna do the chemo after that. And he said, well, this is a pretty aggressive schedule. Like you know what the side effects are? And I said, I do understand the side effects. I'm going to keep going as far as I can go. And then, my plan is do all of this and then go into remission for 10 years. Now we'll see what the cancer is.
That sounds like a good plan.
So
now, I have this question. Did you have, you called it low volume, but you have at least 8 metastases. And oftentimes, if you ask for SBRT with that many, they'll say, no, you should just have generalized systemic treatment. Like, how did you manage to get so many different SBRT treatments?
Well, the first thing, I talked to Steve Lodge, who
was working well. Okay.
the right radiation oncologist, and I met with him, and he said, I'm game if you're game.
Who was it?
Yeah,
the
this
radiation
is Robert Meyer at
Robert Meyer?
Swedish
Okay.
Cancer Institute. And he's awesome. Also, he put me on to a guy here in town. It's a different part of town, pretty much the opposite side of town, where for my SBRT, I could just go. They had like a parking spot like right next to the entrance, and they gave me like a little pass, and they're like, you can park there. And like the radiation oncologist, Dr. Meyer, is like, you should just go over there because parking is really expensive here and it's really hard to find. So I mean, he's kind of like God, like he knows what he's doing. He's on it. And then, I met with him on Friday at the end of the SBRT and went through all the stuff that I had. And he's like, yep. Sounds like you're doing great. So, and I feel like over the weekend, I was like super tired. It was like hard to get up and get anything done. And then today in Seattle, it was super nice. It was like 75 and sunny. So I went running. So I ran 6.5 miles. So that actually helped to take a ton of the fatigue away. And that's what the docs have been telling me too, is just kind of like, yeah, if you get fatigued, just push through it to the extent that you can. And then, I would say like yesterday, I was just like, I can't do anything. And so today I got up this morning and was like, I'm going to do it. I'm just going to go. and the weather helped.
Did you say 25, RJ, did you say 25 miles?
No, 6.5.
Oh, 6.5.
So,
okay.
Yeah,
how,
like
how
10K.
old are you? How old are you, RJ?
I'm 56.
Yeah. You're young, you're vital, you're healthy. You're going all out, triplet therapy, radiation. I would do the exact same thing at your age. Kill it. and you can
All
handle it
right.
because you got a body and the strength and the youth that can handle that. I'd die if I did all of that. You know, I'm an old guy. You're young. You know, I do the same thing at
Well,
your
until
age.
I hit the wall, I haven't hit the wall yet.
Well, it
So
doesn't sound like you have.
yeah, just
Go
some
for it.
bumps along the way. So
Of course.
not that it's been, pain free. I would say the proctitis thing, I was just like, oh, so that's what they're talking about. Oh, that's, and actually, I went running actually when I had that because that actually helped a little bit. Also,
Mm,
just sitting, with the pain was really hard. So it was a distraction more than anything else. And then,
mhm.
so I went and visited my mom because I had this break, and she lives in Michigan. I'm out in Seattle. And so when I was visiting with her, unfortunately, I had that. But when I came back, the doc prescribed those suppositories, and I was like, well, this is, yeah, if I would have known, I would have gotten it
Mm,
before.
yeah.
But at least having gone through that pain, I know what it's like, and I also know what to expect. So, all things considered, I feel fortunate where I am, and also way better than where I was in April and May, where it's just like every time it was like a new test, and it's just like, like
Mhm,
when my test went to undetectable, I was like, yeah, finally I got a good test. Also, I
mhm.
got the DEXA scan, and my bones are good. So it's like my T score was anywhere from like negative zero point 0.1 on up. So
Good.
far so good on that. We'll see where I am after a few years with ADT.
Okay, killing it, RJ.
Thanks. And thanks for all the recommendation from all the people in this group, because I just started out having no idea. And then I remember back in May, like I got that PSMA report, and I like read all the different parts, and everybody was like, yeah, okay, you're in the right group.
Just what you didn't want to hear.
I didn't want that, but also the group helped me a ton, and everybody was like, you'll get it through it. This is we're when you were talking about the low to intermediate risk, it's just kind of like, I mean, there's a ton that you can teach them, but they don't necessarily need to know it. I would say like my knowledge of prostate cancer before I went to the doc, and he said, oh, you have a PSA of 10. I was like, what does that even mean? And now I know.
Yeah, I remember when you first came, it was not pretty.
Yeah, but it's still not necessarily pretty, but is way better, and I feel like I am on the journey, and great guys here to be on the journey with. Thank you.
Thank you. Barry, are you still here?
I'm
Barry?
still here.
Okay, what do you got for us? Some kind of a scan update?
Yeah, so I got halfway through the standard therapy here and went down to Mayo, got a PSMA PET scan or whatever it was. Um, and it was scary because, it showed like my description would be if you stood up a plastic skeleton at about 30 yards and shot it with a shotgun. There were pellet marks everywhere. So I didn't like that. But the the advice was that most of those marks were where they were. If you remember, my PSA was 435 in June, and it dropped to 26, and now it's dropped to 0.24. So Dr. Heath, who's wonderful, basically said, well, when we see those, Barry, we basically pretend like we didn't and move forward. And I like that advice. So I pretend like I haven't seen it. And so now I just got my fourth shot, and, marching hopefully by December, we'll get down to the level that RJ was talking about, and then, figure out what the game plan is going forward, and, what the recommendation is going to be for year 2.
Mm-hmm.
And, but really interesting to hear about some of these alternatives to Lupron and some of the other stuff that's going on. So again, a fantastically informative session here, and the information that's available and the experience that comes through all of you is just a gold mine. Greatly appreciated.
Great. Yeah, we've seen pictures, those kind of shotgun pictures in the literature for ever since PSA scanning first came out, and we've seen them change over time. And of course, those are the ones they publish, but it looks awful, but it isn't necessarily prognostically awful. Not for everybody. Any comments for Barry? Dan with a capital D. Did you want to bring up something?
Yeah, I think the last time I spoke, I was after the meeting because I came on late, so Rick stayed late with me, and he suggested because my oncologist hadn't gave me Casodex before he gave me Lupron shots, he was concerned about his concerns about his knowledge of the cancer. And so he referred me to Dr. McHugh. And so I talked with him. He got my records. I talked with him. And he seemed to be optimistic that he really did know what he's talking about. He said the Casodex is probably an old treatment. And he said, and you're all right and everything like that. So I went to him, and he said, I'm going to get treatment. He gave me, said I'm getting gold star treatment. So that made me feel a little bit more comfortable with my oncologist, where I wasn't feeling so comfortable with him,
Good.
And so he said I have a lesion on my collarbone, and he seemed to think that wasn't related to the cancer. And I need to ask him why he thought that, but he told me that on several occasions. And so, I want to know, then if it's not related to cancer, then why do I have this, this lesion there?
What type of scan showed the lesion on your collarbone?
A PSMA.
This PSMA PET scan.
Yeah.
And that's a fairly specific test. In other words, it lights up when there's prostate cancer. It lights up for other reasons too, but usually it means prostate cancer. Why didn't he think that it was a metastasis?
I asked him, and I don't think I got a straight answer, and so I'm going to ask him in writing, and
Yeah.
So I can get a straight answer from him. He his prognosis for me was better because there's another 5 years added on, or others were, okay, you got about 5 years to go. And, I'm thinking about, things like, how do I break up with my oncologist to go to Sloan Kettering, and, and things like that. But, now I don't have that to worry about because my treatment is on right on course. So.
Okay.
Yeah.
Well, that'll be good feedback, and Rick will probably listen to the recording tonight and find out about your consultation with Dr. McHugh. Was that an in-person consultation, by the way?
No, it was telehealth.
Telehealth.
I got a letter from, I can't remember where, and they said, well, we're no longer doing telehealth anymore. And so right away I called his office up. He said, no, you're still scheduled for Tuesday. So.
Oh, good. So what ADT are you on now? I know you're not on Casodex anymore, but you're on Lupron or Orgovyx or what?
I had a background, and they took me off prednisone because my blood sugar is raised so high. Now they're becoming low, and so I have a feeling that they're going to put me on it next time I go to the doctor. So,
Right.
So you're on abiraterone,
yes,
but temporarily off prednisone.
right,
Hopefully, going to go back on it
right.
if your
And
blood sugar gets under control. Okay. And
hopefully,
what's your main ADT? I didn't even hear you. Was it Lupron?
yeah, Lupron.
Okay, I understand. Okay. And your most recent PSA?
I think it was 2.7. Yeah, 2.7.
0.27 or 2.7?
2.7.
2.7. Okay.
Yeah, it was up to 159 before I
Yeah.
started doing it. Yeah.
Go ahead, Jim. You had a comment.
Let's see. I think I missed him the last time. Are you a veteran?
I am.
You are. Oh, there is a veteran support group that meets tomorrow night.
Really? Yeah. Well, I know about that. I've been
Okay.
kind of hesitant to join it, because my questions would be, well, why aren't they accepting my disability for prostate cancer when it's related to my time in
Well,
service?
that is why you come to the
Okay.
meeting.
The reason that they're not accepting your application is because you haven't talked to Jim Marshall yet.
Okay. Okay. It's tomorrow at 7?
No, tomorrow night anyway, 8 o'clock, within the Schmier room.
But
Okay.
it's
Oh, this
8 o'clock Eastern.
Yeah.
Okay.
8
Okay.
I'm
o'clock
not sure where you
Eastern.
live at, Dan, but it's 8 o'clock Eastern.
New York, yeah.
Okay.
So do I use that same link? I think I got a link.
No, it's a different link. Put your email address to the chat, okay? And the thing I will do is to send you the link.
Okay.
Okay.
Okay. Yeah, and then why can't I copy and paste out of the link?
What?
Why can't I copy and paste out of the link?
The thing that you can do is to save the chat. Okay.
Yeah.
Click on the chat itself. Okay, and across the top you'll see chat, and there is a thumbtack and then 3 dots.
Right.
Click
Yes.
on the
Yeah.
3 dots and it will say
Gotcha.
save chat.
Okay, I see that.
And that will save it somewhere on your computer. Now,
Okay.
you will just have to find it.
Okay, good.
Okay.
Dan, you got your hand up for the last word?
Yeah, definitely. Dan, you got to go to the source here. You missed Jim, so do not bypass Jim in the future. Everybody else, thanks for a great meeting.
Thanks for a great meeting, everybody. If there's anybody that has anything pressing that can't wait till next week, please write to me. And also, Boykin, thank you for coming in on your night off to back me up.
Thanks all.
Good night, everybody.
Thank you.
Thank you, everyone. Good night.
Shit.
Good night.
Good night. Good
It's
night.
John.
All right.
Good night, everyone.
I'm currently writing down a chat, so address here, Danny M.
How long will the chat be available to do that?
Well, how long do you need?
It shouldn't be long. I just didn't know if it was still available, and I'm kind of moved on to my phone.
Okay, on a phone,
No,
I have
actually-
no idea how to save a
right.
chat.
Well, it's too late because the box allowing me to input is no longer there. So But that's fine. All I really needed was that link for the veterans group tomorrow, which is very important to me. But I do
What's
have
your
the
phone
email that
number?
you folks sent.
Wait,
My
what's
phone
your
number
phone number?
area code 530
Okay.
320-6508.
I'll call you in
And I'm
about
done.
3 minutes.
Oh,
Okay.
perfect. And you are?
Jim Marshall.
Oh, very good, Jim. Oh, you're the veterans guy. Very good.
Yes, I
Thank
am
you.
the
I
veterans
appreciate it.
guy. Okay. Okay,
Thank you.
everybody all set? Because I am going to shut it down.
Okay.
End session for all.